Awesome. Marion, maybe I'll start by introducing myself just because you're going to run into the slides right after that. Is that okay with you? Yeah. Okay. You're muted now, Marion.
Yes, thank you.
Yeah. No
Go
worries.
for it, please.
Okay, awesome. I'm Ash. I am a family doctor and addiction medicine doc in Victoria, and I've had the privilege to work with Marion and a couple of other physicians and researchers around an evaluation of the early prescribing practices with risk mitigation here in Victoria through Cool Aid Community Health Centre. In addition to working with Cool Aid, I'm also the acting medical director for addiction medicine for Island Health, so for all of Vancouver Island. So I have a little bit of a leadership administrative hat that I wear, as well as a clinical hat. And I will pass it along to Marion.
Thank you. That's perfect. I'm Marion Selfridge, and I'm the research coordinator at the Cool Aid Community Health Centre. And I also wear another hat where I'm involved with the risk mitigation guidance evaluation that's happening through the Canadian Institute of Substance Use Research, which Gillian Cola has joined us in the last little while. I'm really delighted to be here on the traditional and unceded territorial Tongan speaking peoples to just share with you this preliminary review of the first 6 months of prescribing that happened through the clinic and the sheltering sites that were created surrounding COVID. So I'm going to fly through this. You had a chance to hopefully see the report and was given to you, which will provide a lot more detail than I'm able to do in about 10 minutes, but we want to be able to answer questions as well and just give you a brief overview. So the Cool Aid Clinic provides low barrier health services to approximately 5,000 patients with a focus on those that are economically vulnerable and have complex medical needs and face multiple barriers to accessing care, including homelessness, mental health issues, and problematic substance use. The current overdose crisis, which I'm sure everyone on this call is very aware, has claimed over 20,000 deaths in Canada in the past 5 years. And it's meant that I have lost many people that I knew. We have lost many people at the clinic, community members, patients, drug user advocates connected to us. And so there's a wide variety of strategies that, I'm sure everyone on this call is aware of. And one of them is around this idea of reducing deaths by providing a safe, regulated supply of drugs. We could have discussions about, the efficacy of the way that this is being rolled out, and hopefully we'll have discussions about that through this. So just to contextualize, this initial wave of COVID-19 last March forced closures of programs and services and disrupting the lives of many people who use drugs. These temporary encampments that happen in Victoria and many other places became some of the first sites of alternative prescribing, with outreach nurses and doctors starting the very day after RMG was announced. Over 400 people were housed in temporary sheltering sites and in-house primary care, including ONT and RMG. And I think I missed that section at the beginning, this idea of this risk mitigation guidance that came up through the BC Centre of Substance Use on March 26th. So we had a ton of folks that were housed in these temporary sheltering sites as well. And we quickly identified that this was an important clinical intervention to document through chart review of electronic medical records. So several medical students who were suddenly unable to carry on with their coursework and rounds supported me in reviewing our EMR of all clients who were prescribed through the RMG and entering data into an Excel sheet in order to be able to capture this information. This data was anonymized and analyzed by a colleague, Kiffer Card, at the Canadian Institute of Substance Use Research. He also created this delightful slide deck for me because I'm not this fancy, I can tell you that. So a brief snapshot of the 313 clients who had access to RMG in the first 6 months through our clinic. Over a third of the clients were new to us, lots of folks that we didn't know very well. The majority were men. The mean age was around 40. And the vast majority had been homeless at the time of the initial prescription. And over 60% of those that we offered the prescriptions to had moved into the sheltering sites, mostly empty hotels in the local arena. Lots of recent comorbidities. It just sort of strikes the notion of the impacts of homelessness and the impacts of instability and trauma. Tons of chronic pain, cellulitis, and all kinds of mental health issues that were identified. I'm sure there was a lot more, but we found at least, more than thirds of people with anxiety, depression, PTSD, and close to 40% that had been exposed to hepatitis C. So it totally makes sense that almost all of them described recent illicit substance use. 3/4 of them had a history of injection drug use, and at least 1/4 of them had had an overdose in the past 6 months, most likely more than that, but that was what was captured in the charts. And more than 40% were already prescribed an opiate agonist therapy. So how did these initial, what did these initial prescribing practices look like? So the vast majority were prescribed opioid alternatives, while about 1/4 were offered stimulants, and then close to 20% were offered both. Mostly hydromorphone, you can see there, generally 8 milligram tablets, although there was some oxycodone and MS-Lon when it was in combination with an ORT, then it was conceptualized as an RMG prescription. So the yellow line you can see here in this graph is the initiation, while the red is the cessation or the stopping of the prescription. So you can see that steep build in the first wave of COVID, and then the consistent falling off of folks where potentially RMG prescribing wasn't working for them. And then in terms of stimulant prescribing, about 72% received dexedrine, while 25% received methylphenidate. And you can see it was a much lower curve up there, not as many folks taking it up. So we were able to create this notion of what the max daily doses were for stimulant max daily doses. It was primarily between the sort of 16 to 40 milligram per day range, while the dosing for hydromorphone was broader. And again, this opiate is just hydromorphone. While there were lower dosages of the 4, 5, 8 milligram tablets a day, especially I would say later in the prescribing, these got pushed closer to 14 or 16 milligrams per day. So one of the indicators that we were actually able to assess in this preliminary data was simply whether or not clients stayed on RMG prescription. So in October, when we did this cut of the data, in the chart review, all clients had the chance to be on these prescriptions for at least 60 days because it was from March until the end of August. And for just over 40% that were dispensed RMG, they had this without interruptions, that they were taking it regularly, at least 5 out of 7 days a week. And there was a drop off, as you noticed before. So over 76 of those prescribed opioids were still taking them, but 35% of clients taking prescription stimulants had stopped. So you can see that there was more folks that stopped the stimulants. And when we looked in terms of bivariate analysis about who stayed on RMG, it was people who more likely to stay on who were experiencing chronic pain, had an active OAT prescription, were also receiving mental health medication, endorsed decreased illicit drug use, were older, urgently housed, and were given higher doses of opiate RMG. And to me, this describes a little bit of that actually connecting to pharmacy, connecting to clinicians, kind of buying in a certain way, and hopefully having some relationships that we're building in order to help them stay on. Again, it's hard to tell about the sort of back and forth about what caused what in here, but this is where we're at so far. So the impacts of RMG were measured from patient reports, interpreted through clinician notes. And so it doesn't capture as clearly what would be possible with research directly speaking to people with lived experience of substance use, specifically RMG prescribing. So, chart reviews can only sort of do so much. However, at least 36% reported to a clinician a decrease in their use of illicit drugs. And for those who stayed on RMG, that actually goes up to over 50%. And some other positive outcomes reported by participants included improvements in health and mental health, reduced cravings and withdrawal symptoms, more money to spend in other ways, improved relationships, including those with medical service providers, and an opportunity to focus on health issues like Hep C treatment. The sheltering sites have been an incredible place for Hep C treatment. Not everybody at the sheltering sites was on RMG, but about the 500 people that we've interacted with at those sheltering sites, 95 people 85 people, sorry, were living with Hep C, that they had an RNA. And we've actually treated 60 of those 85 people, with over 40 of them having completed treatment, which I think is just amazing. And you can see all the other kind of engagement that has happened in the sheltering sites as well here. So the most common issue reported in patient charts that was the adverse event, or the thing that wasn't working, was that the RMG doesn't have legs, that there's little or no effect when using their entire dose at once, and the strength of the illicit drug supply across the country, but definitely in British Columbia, especially with the increase in the concentration of fentanyl and the analogs and opioids and stimulants, has meant that clients have concerns that RMG just doesn't provide adequate coverage for their opioid use. They continue to have cravings and withdrawal symptoms. And this sort of brings into this idea of the clinician concerns about RMG diversion by recipients, that they're not getting what they need, and so there's diversion going on to get what they need. And the sort of subsequent suspected population level harms, it's just a discussion back and forth. So it's a significant program challenge that needs further study. Ongoing evaluations of the roles that physicians and nurses play in prescribing RMG is needed. This work is definitely focused on this idea of the prescribers, especially considering the moral hazards inherent in the prescription of potentially dangerous substances that are prescribed under the guidance. So further work is really needed to identify optimal RMG prescribing practices, looking at fentanyl patches, powdered fentanyl, diacetylmorphine, injectable hydromorphone, and for whom those are best appropriate. Thinking about witnessed, individualized, on-demand dispensing in novel sites, might address some of those issues that came up for clinicians. And finally, it's important that policymakers work with communities to find non-medicalized, non-prescription pathways for the provision of acceptable and effective safer drug supply. This is an ongoing policy development process that will require the committed engagement of clients and frontline service providers like yourselves, professional organizations, policymakers at multiple levels of government. Most important is this feedback from the RMG recipients themselves and people with lived and living experience of substance use, which is urgently needed to inform best practices. So just like to thank the Victoria Foundation that gave us open funding to decide what we wanted to do with it. And this is what we decided to focus the money on. The medical students who really, dove into doing chart review, and Kiffer Card from CIFR for his CSER from his data design and analysis, and CoLab, which is part of this larger research team at CISR that I'm involved with, providing input on the development of this project. And of course, all of the clinicians at the clinic and the folks that were involved in all of our sites experiencing this process as we go along. So I will end it there. And if we have any questions, there's some contact information, but more than happy to put it somewhere else as well.
Thanks, Marion.
Sorry, I just flew through that.
It's great. There's so much there, right? And I look forward to talking about it after our next presenters. Dale and Robert, can we ask you to become the next presenters?
Sure. Hi, everyone. So I'm going to give a summary of the preliminary assessment of the safer supply programs funded by Health Canada's substance use addiction program. And I'm Dale McMurchy, and I'm an independent researcher and focus predominantly in public health and primary care. And I really want to start off by acknowledging the staff and clients at the safer supply programs at the 16 sites who have been phenomenal in terms of supporting this research project, both in terms of completing staff surveys. We had 100 responses, program leaders and questionnaires, and I see some familiar names on the Zoom, and facilitating the client interviews that we conducted. And I'll start with the conclusion, and kind of a bold statement, but safer supply works. Certainly the program and services need to be tweaked to improve client experience. And there are a number of barriers that have to be addressed in order to improve the services and ensure that safer supply becomes a broadly available standard of care. And there are important considerations in terms of designing and planning the services. But to the first conclusion, as you can see from these quotes, the program is having a significant impact on clients' lives. And you just can't talk to staff at the Safer Supply programs or their clients and not be in awe of the profound effect that it's having on individuals' lives. And certainly, I mean, Marion presented a very similar list to this one in terms of the various ways in which it is impacting individuals and their lives. And this list is, you know, now being replicated in the published literature and also many reports, and is again emulated here. The Safer Supply medications, very much like Marion said, so across the pilots, mainly it's hydromorphone tablets that are being prescribed as an alternative to opioids. There is some liquid or hydromorphone or iode. Some are providing fentanyl or oxycodone as an alternative. Many of the clients are also receiving a backbone, so codeine and methadone, and quite frankly, to the surprise of some of the pilots, they hadn't necessarily anticipated there'd be a combination therapy, but this is becoming more and more standard of care, and certainly some are prescribing medications for stimulant use. What was notable was that there was no dosages and combinations of medication that was the same across the clients in which we spoke to. And certainly they are taking the reins in terms of managing their own drug use. And for example, some may get tablets in the morning, inject, but then use them as needed throughout the day. Again, as mentioned, it's not without their issues, and certainly tolerance is a huge issue. And prescribers are finding that they're blowing through the guidelines. Maximal doses are like 30 and 35 tablets. And as mentioned, some clients are not, it's not addressing their needs. For many, it is. There are several who are still using street drugs to a lesser extent and cumulatively over time, reducing use, but certainly it continues to be a problem. Supply interruptions, regulatory environment, based the colleges as well as prescribers who need to come on board continues to be an issue. Still, the client time requirements needed for daily pickup are observed. Restarts, so if people have to restart their meds or the dosages are dropped, they may end up back using more street drugs. And diversion, certainly it occurs and is a concern, but in some instances the discussion may in fact be a bit of a diversion in itself. So the other critical piece is that the programs aren't meeting demand. They're turning people away. And even within the resources that they have, there's not enough space or staff to meet the demand of the clients that they're serving, and they can't increase the staff, they don't have space, but even if they increase the space, they don't have the staff. But really critical to the Safer Supply program is the wraparound services that are being provided. And here is a list of the multiple different services that individuals who are receiving Safer Supply are receiving. And it's really important that they are being tailored to the individual and addressing all of the issues that are needed to be addressed for their health and well-being. And that's not without partnerships. And critically, the top partnership relates to harm reduction, and there are very close linkages with safe consumption sites, but also with primary care and pharmacy. When it comes to thinking about kind of what are the key design and implementation considerations, first and foremost is the community-centered approach for designing the program and involving people with lived experience in the design. And as I mentioned, that focus on the client, so providing that entire wraparound of services that individuals need, not just
like, I don't know how far you can you do that or not, right?
The other critical piece is the business of providing services. So having the governance, the managers, the HR piece in place is really, really critical in the crux of providing services. So the people at the coalface can do what they do best, efficiently and effectively. And then also having in place the services and procedures. And some of the participants ran tabletop scenarios about how are we going to deliver services, under what circumstances, what are the intake processes for recruitment, eligibility. And then I mentioned demand and not meeting it, and access, and dealing with drop-ins and clients sometimes having challenges with booked appointments. Retention, so based on this smaller study, the retention was about 90%, and smaller in others. And certainly from the evidence, it's certainly better retention than in the methadone programs. Again, the regulatory environment, pharmacy, physicians and nurses, the colleges, there's issues that need to be dealt with there, and bringing prescribers and dispensers on board. And then the discussions around the critical piece of having safer supply as an integral part of comprehensive primary health care. Absolutely, but as Marion identified, there also needs to be alternative avenues to receive safer supply outside the medical system in a harm reduction approach. So certainly what I'm hearing and what I heard strongly, clearly, is that many participants are looking and feeling better. Certainly we still need to figure out the additional medications that are needed to address, not the least, the tolerance to fentanyl, and continue to tweak the guidelines as needed for dosages. And the critical piece, and I have to thank the pilot sites for the amazing quotes and data that they provided me, such as this one, that we really need to improve the conditions in which people live and address the systemic issues of homelessness, poverty, racism, colonization, trauma, and mental distress, and not assume that the short-term provision of pharmaceuticals will be a sustainable solution for the reducing of or addressing the overdose crisis. So I want you to go for, because just doing this study over kind of 4 months, it really got me thinking about, so what information is needed for safer supply to scale up? And a lot of I've heard a fair bit that we don't have the evidence to support scaling up, and to some extent that's the case, but in some sense it's not the case. And the studies today that are being presented, there is a critical mass of information that is being gathered right now, and there continues to be. And there's small studies and individual sites and within this community of practice that we just need to think about, as this client says, now we're showing success, and how do we get people to realize it and that it makes sense and it's the right thing to do? And there's a handful of people whose minds we change or need information to sort of move forward and get over those barriers, of which there seem to be many, to really make this just a standard of care and widely available. And the public, the governments, health authorities, regulators, professionals, and safer supply services, what information do they need? And this is just one way of thinking about it. So if we slice and dice it and find out among individuals, what information do they need? What is needed in terms of the cognitive changes, or do they need actually the physical, qualitative or quantitative data to move things forward? And how does it need to be packaged? And so for the public, what information and research can we pull together, and what does that look like, and how do we make the case? For example, this is a good one. Public, it makes your community safer. Or for government or the public or the colleges, what information? Well, sometimes it's just dollars and cents. Taking that long list that Marion showed and I showed of all of those outcomes that clients are presenting, they've loud and clear to us that this is making changes in people's lives, and some of this is a no-brainer, but maybe some of it needs to be quantified, and as many of you are doing, maybe put some dollars and cents and say, saving us money. And in fact, it's cost effective. Diacetylmorphine and hydromorphine dominates methadone. So I guess just sort of the thought around the role of this community of practice, and there is a wealth of information in different forms and research that's available, and what's the role of this community of practice around pulling it together, packaging, and making this come to fruition sooner, because we can't wait in the same way that we had to wait with supervised consumption sites. How many peer-reviewed articles do we have to go through before, in fact, it became a mainstream process? And really, this is just really to stimulate conversation, but How do we as a group pull together the information, package it in a way that will move a number of these needles forward? And I just wanted to highlight one other thing. The health learning systems is something that the Alliance for Healthier Communities is starting to put in place within its member centers. And it's a partner in the community of practice. So just highlighting any of the particular methods that we might consider around putting together and packaging the information and research that's available. Thanks.
Amazing, thank you. I am noting questions in the chat for after our next presentation, but thanks, Dale. It's great to hear what you were hearing and seeing, and good questions for us to think about. Tara, are you ready to share with us what you've been up to?
Sorry, too many buttons to click all at once there. Thanks, everybody. Those are 2 hard acts to follow. It's really amazing work and really interesting findings. So I'm really glad I was invited to this talk today. I thought that what I would do is talk a little bit about some of the work that myself and many collaborators, I'm presenting on behalf of many people here, have been doing, trying to measure uptake of safer opioid supply across the province, and some plans for an evaluation of the London program specifically. So that work is still underway, just getting underway actually, but I'm really excited to present here because I see this as a really great opportunity to get some feedback on some of the early data that we're finding and some of the approaches we're taking, and to kind of see how it resounds with people who are working in this area across the province. So myself and the work that we do in the ODPRN and the Ontario Opioid Drug Observatory is largely based on administrative health data. So, you know, every time you go to a hospital, to your physician, or you get a prescription dispensed, that's captured, and we have it all linked and accessible to us as researchers at ICES in Ontario. And so we've been taking on 2 projects looking specifically at safer opioid supply. The first is in collaboration, is being led by Sam Young, who's on the call today, as well as Jillian Kola and Ahmed Bayumi and myself, looking at uptake of safer opioid supply across the province. We know about, you know, some of these larger centers, but one of the things we've been curious about is, you know, are there physicians out there that are just prescribing this to 1 or 2 of their patients, and how can we get a sense of what that dynamic has been over time, and then what the practices seem to look like in terms of who is accessing safer opioid supply, who's prescribing it, and what those characteristics of safer opioid supply are. So that's been the first project that I have some results on that I'll talk about in a second. And the second piece of work that is just getting underway is an evaluation of Dr. Andrea Sereda's program in London. She has provided us with her client data to link to the provincial data sets that we have, so that we can do an evaluation looking at changes over time in a number of different clinical outcomes. So that piece is a collaboration with Dr. Sereda, as well as Jillian Kola, another colleague of ours, Tony Antonio. And that's just getting started. And one of the things I was hoping to get some feedback on was some of the outcomes that we're planning to look at, and getting a sense of whether there's anything else we should be thinking about, as we're literally just about to run this right now, and we have an opportunity to grow that list if it would be helpful. So just for the first project, where we've been measuring uptake across Ontario, the way that we decided to structure this was looking specifically at immediate release hydromorphone. So we're kind of characterizing this as structured hydromorphone programs across the province. And we looked at basically anybody who was receiving daily dispensed 4 daily dispensed 8 milligram hydromorphone tablets, or 8 4 milligrams. So basically 32 milligrams of immediate release hydromorphone daily dispensed for at least 2 of their first 3 days of receiving these medications. And we made sure that there was no other hydromorphone being dispensed in that time, so they weren't also getting, you know, large amounts of long-acting hydromorphone that could be more suggestive of treatment for pain. And we also restricted to people who had some kind of healthcare contact in the last few years related to an opioid use disorder, receiving treatment through methadone or buprenorphine, or had a hospital-treated overdose. So trying to restrict this population to people who seem to have an opioid use disorder and are now accessing some kind of structured hydromorphone program. we looked at new courses of safer opioid supply over the period from 2016 to the first quarter of 2020. And we found 569 new starts of safer opioid supply among 478 unique people. So obviously there are some people, as some of the earlier presentations have shown, who come back and start a couple of times. But what was really interesting, and it wasn't really that surprising, was back in 2016, 2017, we saw about 20 people being started safer opioid supply a quarter, and then starting near the end of 2018, that really started to increase across the province. And when we looked at where these new courses were starting, we looked at health units, and this is really just the top 7. And the places we anticipated standing out did. So, London, Toronto, Ottawa, where we know there are relatively large programs. We also saw, some relatively high numbers of people starting safer opioid supply in Hamilton, Waterloo, Peel, and Sudbury regions, and then a bit of a sprinkling across the rest of the province. So I think in some ways that helped us feel in many ways that this is a bit of a valid definition, because a lot of the places that we anticipated seeing higher rates of safer opioid supply certainly did stand out in the data. But we did see in the lower table that there were about 135 prescribers who only started one patient on what we characterize as safer opioid supply over this study period. So what we're trying to work out right now is whether we think that is truly safer opioid supply prescribing, or prescribing for pain, or at end of life that we are mischaracterizing somehow. So that's the point that we're at this project. We did see that there are 30 prescribers that started at least 3 courses of treatment in their patients over our period of time. And that accounted for 400 of the 569 new courses of safer opioid supply. So we're pretty comfortable with the fact that those prescribers and those individuals are likely recipients of safer opioid supply. And what we're doing right now is trying to tease out those prescribers that seem to be doing it much more sporadically to try and understand those dynamics. And one of the ways that we're looking at that is understanding the demographic and clinical characteristics of people who are starting safer opioid supply. And this is just a brief summary of some of those characteristics. A couple of the things that a lot of this, I think, is expected. I'd be curious what other people around the table think, but in terms of the age and the fact that the vast majority are in urban centers, the skewing towards lower income neighborhoods and the prevalence of HIV and COPD and prior infective complications, I think are kind of as we had expected. We did see that there were about 6% of people who were cancer patients and about 17% who were characterized as palliative care patients. And that's the population we're digging into a little bit right now to try and disentangle whether this could potentially be for pain, for cancer-related pain, or for end-of-life care that might be unrelated to safer opioid supply. We've also been looking at the patterns of use of the hydromorphone to try and better understand, what safer opioid supply looks like. In terms of the maximum dose, it was interesting seeing some of the previous presentations. I think this aligns with what Marion presented. We're seeing about 80 milligrams as the maximum dose per day that people are receiving, but there is a bit of a range around that. On average, we're seeing people staying in treatment about 107, or staying in safer opioid supply programs for about 117 days. Again, with a bit of a range around that, but that's the median time. And just over half of people start getting at least one take-home dose, so aren't getting daily dispense the whole time throughout receiving the structured hydromorphone program. We also saw a pretty high prevalence of co-prescription of medication. So to Dale's point earlier, we are seeing people getting long-acting hydromorphone, benzos, and other types of OAT while also receiving the immediate release hydromorphone. And then about 13% of people who stopped their safer opioid supply did restart. And on average, they restarted about 2 months after stopping their first course of safer opioid supply. So it's also interesting, again, related to the earlier projects, kind of seeing that dynamic as well of some people stopping and then re-entering a little bit later. So for this project, really our next steps are working through that validity of the definition and trying to make sure that we feel pretty confident that we are not including people who are being treated with hydromorphone for pain. But I think we've been doing this for probably longer than we wish to admit right now, trying to refine this definition. And I think we're pretty close now. And then working through trying to complete these descriptions of both the prescribers as well as the people who are able to access safer opioid supply, and also looking at how that may differ based on people who are accessing some of the larger programs versus who might be getting these access to safer opioid supply from a physician who isn't doing this a lot. And that ties back a bit to what Dale was saying around some of those wraparound supports. And, you know, there's structured hydromorphone programs of safer opioid supply, I think is very different based on whether you're part of a program that's providing a lot of wraparound support, perhaps compared to somebody whose primary care provider is prescribing this to them, but isn't basing it within some of these other surrounding supports. And then very quickly, I'm just going to outline in a couple of slides the London program that we're working on this evaluation for. So as I mentioned, we've linked 92 clients from Andreas Reda's program to the ICES data. How we're approaching this is we're matching them to other London residents who have an opioid use disorder diagnosis and are similar to her clients on a lot of different demographic and clinical characteristics, but are not part of her program. She has a pretty lengthy wait list for the program, and we know that there is a lot of demand in London. So we are linking to try and find people who have a similar need, but are not able to access the program at this time. And these are the list of outcomes that we're planning to measure. The way we're doing this is looking monthly in the year prior to people entering into this London program and the year after, so that we can look at their trajectory of access to healthcare previous to entering the program, and if that changes after starting to receive a safer opioid supply. And then we're replicating that among people who are not part of the program to kind of look at those secular trends over time and to then see if it differs between people who are and aren't part of the program. And so we're looking at general ED visits, inpatient acute hospitalizations, mental health hospitalizations, hospital visits for some kind of opioid overdose, any substance use disorder related hospital visit, and then infective complications. So i.e., infections of bone and skin and soft tissue. And then to the point around costs, we're also going to look at total cost of healthcare services to try and demonstrate, if there is that balance of showing that costs can decrease after people enter a program because of some of the health benefits that can come from being part of the program. So kind of offsetting the cost of the medication against the savings from less complications and less healthcare interactions. And so for this one, we're really we've had the data linked finally, and we're working through a few data cleaning checks and are literally writing the code for the analysis right now. So really happy to hear any additional thoughts people might have, any thoughts on other outcomes we might want to think about including as well as we're working through this analysis. And I will stop there. Thank you.
That's amazing. Thank you, Tara. Okay, we're going to move on to discussion. But first, all of you, or many of you, are likely dealing with like reporting and such right now. So you know the importance of statistics. Also, we care a lot about feedback. So we'd love it if you could look at in the chat box. There's a link to a feedback survey. If you could do that for us, we'd be really appreciative. Questions for Dale, Robert, Tara, Ash, Marion. I'd like to open the floor to questions. In the chat, shall I start with the chat? Dale, do you know if there's going to be a publicly available report about your findings?
Yes. So first of all, because I got so much great information from all the pilot sites, the report is a little hefty and it's about 50 pages. So I'm in the process of putting together some summary reports that are much shorter to highlight some of the findings related to the impact on clients and also some of the considerations around implementing safer supply. So those will be available as well as the report.
That's great. I have some questions, but I'd really like to hear from other people on the call first, if you have questions for any of the presenters.
Hey guys, it's Nick
I
Baldwin
actually
here.
have a question. Oh,
Sorry to interrupt, Dale. I was just going to ask you
No,
a
go ahead.
question. I'm a family doc in Kelowna. Thanks a lot for all of your talks and all of your research. I think it's really important to collect sound data on safer supply. Dale, at one point in your talk, you mentioned you briefly alluded to diversion, and then you commented something like you thought the conversation around diversion itself was a diversion. Can you elaborate on what you meant by that?
Sure, and I think probably put a lot more eloquently than I will. In the last community of practice where clients were speaking about kind of what actually happens on the street. So I really wouldn't do it justice, but only to say is that it's happening. Absolutely, it's happening, and there are concerns about how the medications are being used, but in reality, if they're being diverted, there's still safer supply on the street. And that's the argument that people are making. Some people use the safer supply from the street before they enter the programs. And so that I think there's the bottom line is that I think that the discussion there's a lot more complexity to the discussion than, you know, it's being diverted and people are using it on the street because they're using it and it's still a safer supply. I know there is concern that people that otherwise wouldn't use opiates might be accessing it, and so that's definitely needs to be considered in terms of those people's concerns. But that's basically what I heard as part of the study. But I'm not the definitive expert by any means as it relates to diversion.
Nick, maybe I can add to that a little bit, just in the sense that clinicians here in BC, and you as one of them may be aware of this, have started trying to sort of capture a bit more around the new opioid use disorder onset related to dilaudid exposure. It's definitely something that's quite concerning, particularly to a number of our rural and remote physicians, and particularly to a number of our youth-focused physicians. So it's of interest to the province here, and it's something that's been raised a number of times with the ministries and with the OREC, which is the Opioid Response Emergency Committee through the government, and it's definitely something that's on our radar. So if you want to be connected more into those conversations, just send me a message and I'll let you know how to track that within your patient population as well.
Yeah, that'd be great, Ash. Thanks. Yeah, I mean, I think that's one of the few things that gives us pause about unwitnessed safer supply is the risk of iatrogenic addiction. And I think it is low risk. I think most people are either taking, it seems, but it's really hard to study and follow and track. But yeah, like you said, Dale, if people are selling it, who is buying it is, if they're buying it as an alternative to fentanyl, that's a good thing. If someone doesn't already have an established opioid use disorder and they're opioid naive and they're buying it, I think that's what all kind of keeps us up at night. And we've seen, I mean, it's anecdotal, we don't have any hard data, but we've now had a handful admitted to our detox here that initiated hydromorphone use in the last 12 months and hadn't used opioids before that. But yeah, I think it's the more we can study it and gather data, the better. And then just to change gears a little bit, Tara, I was really interested in your data in Ontario. There's a relatively low amount of people getting safer supply that were co-prescribed opiate agonist therapy. I think it was less than a third. Do you have any comments on that? That was interesting finding to me.
Yeah, I mean, we looked at a few different OATs. So I think if you looked at any, we'd probably see a slightly higher percentage. I don't know, maybe Jillian, who's I think here on the call somewhere, might want to chime in because she's most familiar with some of those dynamics. Sorry to put you on the spot, Jillian.
Sorry, I'm dealing with a second grade math crisis at the same time. Could you just repeat the question really quickly?
Sorry, it's just about the degree of OAT, combined OAT use during safer opioid supply being a bit lower than maybe anticipated.
Yes, I think that that's one of the interesting dynamics to be keeping an eye on in a lot of these evaluations, because from some of the initial work that we've done with some of the programs, such a high proportion of people who are starting on safer supply have previously been on OAT, and it has not worked out for them for a multitude of different reasons. I think that there's the system and structural level ones, there's access level issues, and then there's just the fact that a lot of the OAT meds don't really work well for people, and that's one of the reasons why they don't end up continuing on treatment. And so I think that looking at the dynamics of how it works, and also the fact that this is going to be, there's not going to be one standard prescription that's going to work for everybody. I think that looking at some of the different options that are available to people, so methadone backbones with immediate release hydromorphone, Cadian backbones with immediate release hydromorphone paired onto it. I think that looking at some of these dynamics and the prescribing and what's working for people is actually one of the very open research questions to be investigating over the next little while.
And if I could just pipe in, and certainly even back to the diversion issue, that every client that I spoke to and the staff, there is no one prescription that I saw that was similar in terms of dosage, combination therapy, kind of harking back a little bit to HIV, in fact. And one of the key problems is that there are these, people are going through the guidelines, and I found it very interesting that the max finding in chart review is very different from, what I'm seeing in terms of what people are being prescribed and what clinicians are saying they're maxing out at, 30 and 35 tabs. So what's happening, it's not working for people, so they have to divert back to, again, their kind of existing prescriptions aren't working. So there's a really complicated matrix, Rubik's Cube, that needs to be addressed, I think, in this particular area.
Yeah, and clinically, that's certainly what I've experienced. Like, I myself have probably prescribed for over 100 individuals for RMG, and I've had many of my patients who I've had long-standing relationships with come to me and actually tell me that the Dilaudid is just really not working for them, and they are choosing to cancel the prescription and instead to have a more focused conversation about what could work for them. And I think part of that is just relational care in terms of being able to have an honest conversation with people when there's a relationship that's built up around that. And it's really unfortunate that in many of these situations where we don't have that relational kind of ability with patients, that we're often forcing people into positions where they have to lie. And I just think that's a really problematic aspect of care, patient-centered care in general, is that we need to be working towards solutions that offer patients the opioid tolerance needs to be met, rather than continuing, for many of the patients that I work with here in BC who have extremely high opioid tolerance levels, rather than continuing to offer options for them that really just aren't offering a competitive alternative to what they're experiencing through street substances.
Ash, can I ask a follow-up question to that? How much of that do you think is due to the fact that we just have such a limited number of options available in terms of what is available for people? Because one of the things that we're hearing so much here in Ontario is that there's so many limits on the drugs that are available that are covered by the Ontario Drug Benefit. In BC, you have a little bit more of there's a bit more options. But the fact that we don't have heroin, that we don't have injectable hydromorphone here in Ontario anyway, in the doses needed, that we don't have the opioid options. Do you think that that plays into it at all?
Yeah, I mean, we still have really restricted options for people in BC as well. Like, even currently, we still need special authority approval for fentanyl patches that have a concurrent disorder of pain, chronic pain, and opioid use disorder. The province is moving towards kind of removing that restriction, but still currently with fentanyl patches, that's the case. So hopefully that'll change quickly, and we'll be able to sort of upscale fentanyl patches and access to that as an option for individuals. I think ultimately what it comes down to, which is difficult to talk about, at least in BC, but is the reality, is that we're actually up against organized crime. And so we as prescribers are constantly trying to navigate an increasingly toxic and complex drug supply with prescriptions that just truly aren't meeting the needs of that complexity. So now we're dealing with, extremely high potency benzo additives in our street supply here in BC. And that's just changing the landscape for prescribers around what we're doing and how we're doing it, and how we're connecting with patients around this incredible level of risk that they're experiencing. And ultimately, I think what we're trying to get to in BC is really a much stronger understanding of the fact that prescription pads and the substances that we have available really are not the answer long term. We need to be looking at models that are government supported, that allow for us to do things like offer compassion clubs, collaborative, cooperative settings where people can be much more in control of what's happening with a safe supply and be much more able to pivot quickly. Anytime we have a system in place that is reliant upon prescribers, there's going to be so many barriers to be able to pivot within that system. And ultimately, we need something that's going to be able to be responsive to the changing nature of the toxic drug supply. And right now, we just don't have that model. So I think for us here as prescribers in BC, and for many of us who've been involved in those conversations, what we're trying to do is really pressure government to say, you do have power over the Controlled Drug Substances Act. You do have power over Section 56. You can make changes. Yes, it's not politically, has a big political appetite a lot of the time, but we do need to be pushing for structural change and not just relying upon a really poorly positioned program that allows for a high level of gatekeeping with prescribers to meet this incredible risk that our patients are living with on a day-to-day basis. I myself have had 18 of my patients die from overdoses since the beginning of COVID. It's extremely difficult to live. I can't even imagine how difficult it is for people to live with this level of risk right now. And to see barrier after barrier after barrier to systems must be so incredibly painful for people. So I think the more that we are able to move to true structural change that allows for cooperative models, that allows for people to be in control of the systems that can support them, the better off we're going to be. That's just my little soapbox.
Thanks, Ash. You're getting lots of like thumbs up and cheers to you for that. Thanks. I do acknowledge the time, so I just want to say goodbye to those who have to leave. But Tara, if you have a minute, I want to ask you a quick question and about what you presented. But thanks to those who were able to join. And if you can stay for a couple more minutes, that's great too. We will share this this presentation and slides if I can get them from the presenters, and let you know what's coming next from the community of practice. Tara, one of the things I've been wondering a lot about is looking at when we talk about the argument around cost effectiveness around healthcare savings, health service savings that may be accrued through safer opioid supply prescribing. One of the things that I think we are seeing in our programs are people accessing more health, like preventative health care, primary care, having their chronic disease management, that kind of thing. So I almost wonder if seeing some increases in access to some types of services, like we want to see ED use down, but like seeing increased costs related to chronic disease management and that sort of thing seems to me a good thing. So when you were showing that, you know, you're looking at the service utilization and costs associated a year prior and then a year post, I wondered, like, is a year enough to show cost effectiveness? Or like, do you need to just focus very specifically on ED use, or can you speak to that?
Yeah, no, it's a really good point. It's something that's come up in the conversations around this. So one of the things my slide ran out of space, but in the cost, we actually can break it down. So we can look at hospital costs, physician costs, medication costs. So we can separate it out that way. And part of the, I think, nuance to interpreting what we see is going to have to be based in that. So, you know, ideally we see less hospital related costs, and those are often more expensive anyway. But if people are getting more access, more referrals to specialists, more access to primary care to manage their complex chronic medical conditions, then we can see those costs increase. And we don't want to suggest that that is a negative thing, right? So that's one of the reasons why we need to not just say, here's total cost and this is going up or down and that is good or bad, but actually then delving into exactly what those costs are related to, and perhaps even trying to build in some ways of looking at people navigating it through specialist care and that kind of thing, right? So like, are people accessing specialists more in terms of that being a good thing, and how are they actually being able to navigate the healthcare system? And so that is something that's part of these conversations. I think we're going to start with breaking down the costs and then seeing whether we need to investigate some of those dynamics more.
Amazing, thank you. Yeah, and then I just wanted to also point out one of the themes that stuck out to me during all three presentations was around this issue around defining safer supply, and the different ways that it is conceptualized in the different language that we use to talk about safer supply. So for example, like safer supply being inclusive from IOT to the structured hydromorphone project, what did you call it, Tara?
Structured hydromorphone program. That was our consensus after a lot of debate.
Yeah, like that's great. And I've heard that talked about in different ways too. The Ontario model, flexible model, there's all these different ways, risk mitigation guidelines. And I'm really interested, and was just talking about this with a research group from the research working group from the Safe Supply Working Group through CDPC, and about how we conceptualize and how the words that we use and how that reflects different contexts and agendas and that kind of a thing. So I think that's another piece to keep talking about and looking at. Why risk mitigation program instead of source supply, for example. Thanks, Tara. Instead of safe supply. Questions like that, like I just find it really interesting in terms of like discourses and advocacy and making a new program palatable to people who may feel that it's controversial and things like that. Any other last thoughts from other people before we say goodbye for today?
I just had one quick thought, actually, Erica, related to the costing and perhaps there's that there's an option to also model this out and create longer term models around cost avoided in future for treating chronic conditions and primary care access now, and what that looks like in the future. And so even modeling out costs of reduced healthcare, reduced with the justice system. There's lots of opportunities, I think, for that modeling to actually make the case in advance of what we know is going to happen in a sense.
There is actually somebody in London doing that. A researcher from IB Business School is doing some work around that based on data from the London program, some modeling around that. But things aren't, Lauren Cipriano, I think I'm saying getting her last name right. Jillian, do you know? And yeah, I actually contacted her as well. I also contacted her as well to see if she might be interested in joining us for one of these meetings. And this is too early right now. COVID's keeping her really busy, but she does look forward to getting into doing that study and that modeling. And we'll share when the time comes. Great. Thank you all for the presentations that you gave today, Marion, Ash, Dale, and Robert, and Tara's gone now. And thank you all for joining us for this meeting today.
Thanks, everyone. We'll be posting the materials on the Google Drive too.
Thank you.
Thanks.